It is purely for the educational purposes of healthcare providers and researchers. And if you don't go along with that and you put my name in the chart, this is how it's spelled here. The T is silent. Sorry about that, Laura.
Oh my, I'll still love you.
So we're going to start off with a patient, and this is actually the first or second patient I ever saw. I saw him in the late 90s. He is a 29-year-old gentleman with autosomal dominant osteopetrosis. I met him actually in the hospital. His chief complaint was fatigue. He had chronic osteomyelitis of the mandible, multiple fractures with multiple non-unions. He was anemic. He had multiple transfusions, was being taken care of by a hematologist, and had extramedullary hematopoiesis. Family history, his father, paternal aunt, and cousin were all affected, and this was an autosomal dominant pattern, and his wife was 36 weeks gestation pregnant. On physical exam, his vital signs, blood pressure was 110/70, his pulse was 150, he was afebrile, he had very pale conjunctiva, he had swelling and tenderness over his right mandible, and cutaneous communication draining pus out of his right mandible. He had a 3/6 systolic ejection murmur at the left sternal border, and his spleen crossed the midline and was palpable into the pelvis and was clearly the largest spleen I've ever palpated in my 30-some-year career. His white count was very diminished at 0.3. His hemoglobin was 3.5. Platelets were 52K. He was a transfusion challenge, to say the least. Actually, he was a transfusion nightmare. And his bone mineral density on DEXA at the time, he had a Z-score of plus 16.4 of his femoral neck. This is his liver and spleen scan at the time, and you can see his spleen was actually about the same size, maybe slightly larger than his liver. This was his femur, and you can see here he's got the classic Erlenmeyer-Flask deformity here. And this was really the patient that got me interested in this disease. I had just arrived at IU, and I actually started seeing these patients and then decided to open up a research program on this. Just to start as a definition of osteopetrosis, this is Michael White's definition, which is to this day the best definition. All true forms are caused by impaired osteoclast-mediated bone resorption of the skeleton. And there are several types, and we're going to go over the recessive type a little bit, and that is, quote unquote, I hate this term, the malignant form. These patients tend to be very severe. There is also another autosomal recessive that Michael White actually described, which is due to carbonic anhydrase 2 deficiency. There's been described in the literature this term intermediate osteopetrosis, and it's probably not a distinct entity. What makes up this group of patients are milder recessive patients and more severe autosomal dominant patients. And I don't actually like this term. I'd rather define the disease in terms of its inheritance of its genetics. Autosomal dominant was originally described as the benign form of the disease. This is clearly, as you're going to see, a misnomer. Certainly this gentleman had autosomal dominant osteopetrosis, and this was by no means benign in him. The type 1 is not an osteopetrosis. It's now referred to as high bone mass. It's due to LRP5 activating mutations. And the type 2 is the type that our patient had and is the more common, actually the most common type of osteopetrosis. So the autosomal recessive we'll talk about briefly, and we will have a case presentation in a bit. It's usually fatal during infancy or early childhood if it's not treated. Typically, patients present with multiple cranial nerve deficits, including optic, oculomotor, and facial nerves. Most are blind by the time of diagnosis, which typically occurs in infancy. They have pathologic fractures, recurrent infection, bone marrow failure due to marrow crowding, and fibrosis. And then two of the types, those caused by chloride channel 7 and OSTM1, mutations, are associated with neuronal degeneration. So, sequencing approaches. In the good old days, more than 10 years ago, you did a careful clinical, biochemical, radiographic, and histologic evaluation, and then you chose the genes to sequence. Now, the modern approach is really sequence them all, let the bioinformatics guy figure it out. This is really the most cost-effective way now that sequencing costs have come down. The recessive, we typically separate into osteoclast rich, which are the majority of the recessive forms, from osteoclast poor, as the therapy actually varies. Patients with mutations, for example, in rank ligand, will not respond to bone marrow transplant. Biochemically, the tartrate-resistant acid phosphatase is not increase in the osteoclast poor, and the patients with the osteoclast rich or the rank ligand mutations may respond to bone marrow transplant, which is actually the therapy of choice for these patients. This is just a slide from a terrific review, still one of the best reviews out there. And the long and the short of it is there are a lot of ways to ruin osteoclast function. The most common mutations for the recessive are in the TIGRG1 gene, that's about 50% of them. Chloride channel and OSTM1 are also common. And what happens is you get an osteoclast that just doesn't work. As far as osteoclast poor, there are two basic types. One is in rank ligand, and the other is in rank, and these give you low numbers of osteoclasts. As I said earlier, the rank ligand mutations won't respond to bone marrow transplant. And again, this is the reason for making these genetic diagnoses, because you don't want to transplant somebody who's not going to respond. Interestingly, chloride channel 7 mutations cause both autosomal recessive and autosomal dominant disease. And biallelic mutations cause typical autosomal recessive, both in the human and the mouse. The recessives, as I mentioned earlier, do tend to have a severe neurologic phenotype in babies. The mutations that knock out the protein entirely do not cause disease in heterozygotes. So it's really missense mutations in chloride channel that result in an amino acid substitution that affects the protein function. And this results in a dominant negative mechanism and gives you the osteopetrosis. So it's interesting that this gene can cause either recessive or dominant disease. And this is, I'm just going to go through a few quick radiographs to show you some classic findings. This is your classic rubber jersey spine where you have osteosclerosis at the vertebral end plates. You can see it in this X-ray. It's much more subtle here. And indeed, when we went back, when we first started doing research in this in the late 90s, and we went back to some of the teenagers' films that they had, just incidentally, we could find very subtle evidence of sclerosis along the plates in some of the kids that were moderately affected. This is a classic bone-in-bone appearance here. It looks like a little pelvis is embedded in the larger pelvis. We're going to get back to this idea in just a couple slides because I think this is going to tell us something not only clinically, but from a more basic science perspective. These are some other examples of the bone in bone kind of appearance here and here, here. And this is a great example, and I'm going to use this film here as an example of a way of letting clinical information give you some hypotheses about the mechanisms of disease here. This patient, this calcaneus continues to grow. And what happened was you see a lot of sclerotic bone here. But then here you see it's not quite as dense. It may not be normal density, but it's not quite as dense. And to me, same thing here. To me, what this is telling me a little bit is that this osteoclast impairment is not always uniform throughout life. Otherwise, this whole thing would be very dense. Similarly, if we go back a couple slides and look here, this part is very dense here, but this is a little less dense. It's still hyperdense, but less dense than here. And so this patient, their mutation didn't change. Something happened to allow their osteoclast to resorb bone a little bit better. If we could figure what that was, we would go a long way towards treating the disease. So as far as complications of the disease, the most common complication is fracture. We also have in the dominant form as well visual loss due to encroachment of the optic nerve here by bone. You can see the nerve is being pinched off here.
Dr. Econs,
yes.
If I may interrupt you for one moment. We can't see your cursor.
Ah, okay. So I will change it to a laser pointer. Okay. So can you see it now?
Yes, we can. Thank you.
Okay, so that's being pinched off right here. Okay. I apologize. Osteonecrosis and osteomyelitis also occurs, particularly in the mandible and the maxilla. This fellow had about a 2-centimeter hole in his hard palate here. And this is the same patient. I think you can see a little osteonecrosis right here. This is a different patient, and she had lost a good piece of her jaw to her mandible to this process. This is an overview slide that we published, Stephen Waggis back when he was in our lab. We published this in 2007, looking at, patients who were affected by this disease. And the green is for the children, and the white is for adults. And by the time people in adulthood, almost everybody had fractured who had clinical disease. And then we define severe fractures as having greater than 10 fractures, excluding fingers and toes, or having a hip fracture. And so even in the kids, there were a number, 16% had what we called severe fractures. Osteomyelitis was much more common in adults. And we had a very high rate of visual loss in our sample, which was skewed compared to Dr. Beneshu's sample, where he had about 5% vision loss. We had less bone marrow failure, but I can tell you today we're seeing a lot more people with bone marrow failure. And again, if you have bone marrow failure, you tend to have severe fractures, and you're one of the folks who also have some of the other more severe or complications of the disease. And then in the same paper, we were privileged to go back to Con Johnston's 1968 paper in Medicine, where he really defined some of the phenotype of the disease, and go back and look at 6 patients, essentially 30 years later in the late 90s. And what we found is we found some asymptomatic people who were still asymptomatic, 2 who were asymptomatic who migrated to having mild disease, 2 who had mild disease who now had severe disease, And if you were severe to start, nobody got better. It seemed that people tended to get worse. Now, this is a small n, but it's something that we've been very interested in over the course of the years. This is a family we published quite a while back, but we're still following them. And this is a woman, the grandmother here had very severe, she actually had mild disease as a child, but very severe disease in her 60s with bilateral hip fractures, as you can see here. Her daughter on DEXA had a Z-score of minus 0.4, so totally normal. Unfortunately, she was told that that she could not, because she was unaffected and this was a dominant disease, she could not have children with the disease, which was absolutely wrong. She had 3 children, and 2 of whom clearly had evidence of the disease here. The disease penetrance is only 2/3. So 1/3 of people who have the mutation don't have clinically evident disease. And as you can see here, some people everybody in this family has the exact same mutation. Even before we found the disease gene, we knew that these people all had the exact same mutation. This person's very severe, this person's a carrier, this one is moderate, and this one's mild. And all had inherited it from their mother. So there was no imprinting and there was actually no evidence of anticipation. We've since followed these 2 fellows here, and we have repeat radiographs. And so this radiograph is the one these 2 are the ones I just showed you. And this is age 9 and age 6. And now, 18 years later, we took these radiographs, and you can see this young man has progressed, but still has moderate disease, and he's not fracturing. This one, however, went from mild to, again, more moderate disease, giving us, again, a hint that the disease may be getting worse with age, at least in some individuals. We made a mouse model. We published this with Anna Teddy's group a while back. This is looking at mice as they age. The blue is for boys and the pink is for girls. We set wild type at 100%. This is bone density, bone volume per total volume. And as you can see in the young mice, who I think were 12 weeks of age, they have about a 2-fold increase in BB over TV. But in the older mice, who were, I think, 15 months of age, they markedly increase their BB over TV, indicating that in the mice, the disease also seems to get worse with age. Therapy for the recessives, bone marrow transplant is clearly the only available therapy. There is bridge therapy with gamma interferon to get you to where you can find a donor, et cetera. There's a very high mortality with the bone marrow transplant. For autosomal dominant, I'm going to very briefly review medical, bone marrow transplant, and surgical, and we're going to talk about bone marrow transplant in some of the cases. Medical therapy, we've tried a couple things, and this is just one slide to show you that gamma interferon, we did a 14-week trial with Eric Immel and myself and several others. And in 14 weeks, we tried to see if maximally tolerated doses of gamma interferon would increase markers of bone resorption, either CTX or NTX, or increased fasting urinary calcium to creatinine ratios. And the long of it and short of it all is that there was no change in either NTX or CTX over the course of the 14 weeks therapy. Then we had them at 4 weeks later come in. And so there was absolutely no change, indicating that it really wasn't worthwhile to do a 2-year study, which this study was supposed to lead to. Had we had increased resorption, we would have then gone on to do a much longer study. So The long and the short is neither calcitriol, which I didn't show you data on in mice, and certainly my personal experience in humans show that that did not work, nor gamma interferon seemed to work as medical therapies. I might add that we are working on a number of things in our mice now, so stay tuned for that. And this is a study done a while back by Kang Chu in our lab, just showing that we took 6 trios of people typically from the same family. One was a clinically affected subject. Another one had the exact same mutation, but was a carrier, and then normal control. And so the carriers and the controls had the exact same mutation, and which you can see, excuse me, the carriers and the affecteds had the exact same mutation. And what you can see here is the clinically affected subjects, their osteoclasts in culture, these are pit resorption assays showing how much the osteoclasts resorb bone in culture didn't work, where the carriers were pretty much the same as the controls. And this indicated that the difference between carriers and affecteds was really in the osteoclast itself. It wasn't part of the bone microenvironment, which really interested us and indicated that bone marrow transplant might work. I'm going to show you some more data on that in just a little bit. Actually, this slide here. So in our experience with bone marrow transplant, it's been frankly disappointing. And the successful bone marrow transplants in adults have actually occurred, and this is a very nice paper here in Blood Advances from last year. They've really occurred in milder autosomal recessive patients, not so much, not in the dominants. And this is really an example of why we need to work together in rare disease, because I wouldn't really have this experience except because we only had 2 patients who went for transplant. But when we first started working with Linda Palgreen and Paula Orchard, Linda at UCLA Harbor and Paul at University of Minnesota, and we kind of put our experiences together, we realized that our experience with the dominant form of osteopetrosis was not stellar in the humans. Now, my lab is doing bone marrow transplant in mouse models. The results aren't out yet completely, but I can tell you they're not overwhelming, and particularly in the old mice, the 9-month-old mice, we're not having terrific results. And we'll see how we do in the younger mice. But this is really a concern, and it will come up in some of the cases right now that we'll be presenting. So, summary of therapy. Calcitriol and gamma interferon don't work for medical therapies. We have a number of compounds ongoing in both cell culture and mouse studies. Surgical therapy, I joke about this. Find a surgeon you don't like, because these are really, really difficult operations, either for the neurosurgeon or the orthopedic surgeon. And the 2 people that are willing to, types of people that are surgeons that are willing to operate on this are either people who have never done it before, or people who are very dedicated, like Dr. Tosi, who are willing to take on really difficult cases. And if you find one of those folks, really latch on to them, because they're terrific. They're terrific to have in your group, because these are really hard patients to operate on. So to summarize, autosomal recessive osteopetrosis is fairly, well, it's always severe. The intermediate forms are still pretty severe, but some of them are living into the teens and 20s. Current therapy is bone marrow transplant. Some of the long-term survivors may actually be confused as having the dominant form, but they have the recessive form. In the autosomal dominant form, disease severity is widely variable, but most patients fracture. 1/3 of the subjects with osteopetrosis mutations are carriers, and the severity in some of the manifestation likely advances with age. I would also point out that in all of our families that were large enough to see this, families had both carriers and severely affected individuals. So there's not a genotype-phenotype relationship so much. This is just a true non-penetrance. Finally, I'd like to thank a lot of my collaborators who some have worked with me years back, many of whom are current collaborators. And I'd like to thank our patients, and particularly the OPETS patient group. And finally, I want to, if we don't, when we go over the cases, I'd like to make sure we cover these issues. And with that, I will open it up for the cases.
So thank you very much. Michael, just in case, may I be rude and say, would you speak to some of these points even before we get going? Because the clinical management is always so difficult with these kiddos.
Okay, so for oral surgical issues, what I've typically done, and we've had some success, is partner with one oral surgeon, although they keep leaving me, and an infectious disease person. And these are very difficult issues to deal with. And what we've typically done is the infectious disease person will rotate antibiotics, and the oral surgeon will conservatively debride where necessary, but not try to, where you get into trouble, I think, is trying to debride to healthy bone, because there's not healthy bone. We can talk about this a little bit more, but these issues have been rather tough, I would say, but we've managed success in a fair number of cases. And very often we're able to get somebody who's got a chronic cutaneous drainage to actually heal them up. We have done that. Saving vision in children at risk is something that we've done. We feel that we've saved a few eyes. Typically, so the protocol that we've used is we send the kids to a pediatric ophthalmologist for exams every 6 months. And then if there's any concern, the ophthalmologist gets an imaging study of the optic nerves. And if the optic nerve looks like it's going to be choked off, we call in the neurosurgeon. Now, these are very difficult neurosurgery procedures. Remember, this is called marble bone disease. And Dr. Tosi has operated on these folks, so she knows it's hard. And what they do is they unroof the canal and open up vision. And at least in 2 of our kids around the age of 4, we lost 1 eye, but we actually saved 3 eyes in those 2 kids. Osteomyelitis outside of the bones and the jaws is another thing where we work extensively with the orthopedic surgeon and the infectious disease person. Some of these are very, very difficult to deal with. And some of the patients, frankly, the best you can do is sort of beat it down to a dull roar. And then I just mentioned potential limitation of activity in children and adults. And this is really something where there's really no data. And because each patient is fundamentally different, because the severity varies from carrier to mildly affected to moderately to severely affected, you really have to individualize each recommendations for each child and each adult. And those recommendations may change over the years. Really risk avoidance in kids is very tough. Many of the members of the audience and the physicians here have dealt with children with a wide variety of rare diseases. And it is hard sometimes to counsel them. They always want to know what they can and can't. The parents want to know what they can and can't do. And you can't give them a hard line. You have to give them guidance to tell them that they're at increased risk. And again, part of this is based on your clinical, kind of look at the kid. How many times have they fractured, or the adult? How many times have they fractured? If the Z-score is +4, they're way less risk than if the Z-score is +16. Does that help?
That's terrific. Thank you. I just think it's particularly important. And actually, you surprised me that you're checking the vision that often. These key clinical points are always so important, and you've just changed my practice. So thank you.
Okay. Yeah, the 6 months I think is important. Again, so after age 18, we've not seen anybody lose vision. It's really only important in kids, but particularly in the severely affected 4 or 5-year-old, because loss of vision is, in my view, a fairly high disease burden. I really want, and again, I work with pediatricians. I'm an internist. Eric Immel is med peds, and Linda DiMiglio is pediatrician, and I work with them extensively. But we've really kind of said, let's get them to see the pediatric ophthalmologist every 6 months. Watch them like a hawk. If there's an indication, if there's a hint that there's something wrong, go ahead and do the imaging. So you can save vision in a lot of these folks.
That's terrific. So before we move into our incredible cases, I just wanted to pause for a second and remind everyone to please sign into the chat room. We want to be sure that you get your CME if you would like it. That's for sure. And we will be sending out, this has been a great year. Thank you for everyone who has participated. We will be sending out the schedule for our second year in a day or two. We've grown incredibly in terms of the number of people participating, and we hope you'll find next year's agenda equally exciting.
So also, Michael, I think I'm supposed to remind you to stop recording for the cases.
Right.